So without further ado, it's my privilege and honor to have one of my, I guess, good friends speak today at our second Yale IR Grand Rounds. For those of you that have participated in the Grand Rounds before, this is not deja vu. Rony was actually our Grand Round speaker for the department, so departmental Grand Rounds back in October of 2019, where he gave a great talk on immuno-oncology and the role of imaging in that. So what we wanted to do today for interventional radiology Grand Rounds is a little different. And before we get into the topic, I think what we'll do is just give you a little bit of background. Unfortunately, I did not save my notes from the previous talk, so this is going to come off from scratch again. But I've known Rony since about the year 2000. Just to give you his background, he got his medical degree at the University of Sao Paulo in Sao Paulo, Brazil in 1995. Did a clinical residency in diagnostic radiology at the University of Sao Paulo, where he did that from 1996 to 1998, and then moved to Houston to be a general surgery intern at the University of Texas Health Sciences Center, where he then also did his radiology residency from 1999 to 2003, and that's actually where I first met him. And then he became a clinical fellow in IR at MD Anderson, which is, for many of you know, is actually a combined residency program between 3 hospitals within the center. So since that time, he's risen from an assistant professor to now a full professor. He's the director of preclinical research in the Department of Interventional Radiology, and also serves as chair of the Interventional Radiology Research Seminar Series, something that I actually developed back in the early 2000s. He also served as section editor for Interventional Oncology for JVIR, which he did during my tenure as a deputy editor. He's also has numerous publications in key journals, which include Cancer, JVIR, CVIR, and others. And we've worked very closely together in the animal facility at MD Anderson, where we were able to create an animal model for cirrhosis that we're still using here to this day. He's also served as in the grant review capacity for both SIR and SIO, and is a journal reviewer for numerous journals, including Cancer Research. So I thought that it would be a great idea to discuss his work on chemoembolization. And as you know, we do a lot of that here. So what Rony is going to talk about today is the effect of bead size and doxorubicin loading on tumor cellular injury after transarterial embolization. So with that, Rony, take it away.
David, thank you for the wonderful introduction and the invitation to present my research. The reality is that when I started, a long time ago at MD Anderson with David, he was the first one that introduced me to the animal lab, and my love for animal research came from my interactions with him and his mentorship. So I owe him a great deal, and this is what I've since then been mostly involved, and it's been a great source of personal and professional pleasure for me. So today I'd like to discuss a series of experiments that we did, trying to understand how different embolic agents affect the tumor microenvironment and how that can play a role in combination therapies in the context of interventional oncology. In 2020, there was a seminal publication in the New England Journal of Medicine from the IMbrave 150 trial that truly established the role of immunotherapy as a frontline agent for patients with advanced hepatocellular carcinoma. And as you can see here, the combination of the immunotherapy with a VEGF inhibitor led to a dramatic change in patient survival from 54% with sorafenib, which at that point was your first-line therapy, to 67% at 12 months, and a progression-free survival change from 4.3 months to 6.8 months. And it's important to also emphasize that for many years, over a decade, many trials tried to establish the superiority to sorafenib and failed. So sorafenib had been the only systemic drug for advanced HCC patients for over a decade before this this significant trial. So I start the lecture with this because it has then shifted the way we look at this disease. And as interventional oncologists, very closely tied with treatment of these patients, I think it's important to understand the limitations of these new paradigm and how we can help improve the outcomes. And exactly in that line, I pointed out the response rates. So even in the best available systemic therapy, we get response rates that are less than 30% compared to sorafenib, which is about 12%. What is the rationale behind combining those two agents, an immunotherapy and angiogenesis inhibitor? The rationale revolves around the central role that VEGF plays in changing the environment of the tumor cells and the stroma surrounding the tumor cells. As the tumors grow and the center of the tumor outstrips the vasculature, there is an increased amount of hypoxia in the tumor and in tumor cells, leading to increased expression of HIF-1 alpha and then increased expression of VEGF. So not only, which is important to realize, not only the VEGF increased expression leads to increased angiogenesis, but it does promote a series of cellular changes surrounding the tumor cells that are mostly immunosuppressive in nature. So it attracts macrophages and attracts other myeloid cells that produce a series of agents that block the actions of T cells, as well as block the access of the other immune cells from the innate immune system to the cancer cell. So by combining bevacizumab with atezolizumab, we are trying to overcome some of these barriers to cancer treatment. So what do they do individually? Specifically, the VEGF inhibitors try to normalize. That means basically the irregular, abnormal vasculature of the tumor, once exposed to these drugs, become a more normal vasculature, therefore allowing the T cells to reach the center, or at least the periphery of the tumor. Bevacizumab will also reduce the activity of some of these immunosuppressive cells, already mentioned MDSCs and Tregs, thereby restoring the possibility of the T cells to kill some of these tumor cells. The atezolizumab, it's important to notice, needs the T cells in order to be effective. So if you are giving immunotherapy, it only works if you have tumors, T cells within the tumors. So without the bevacizumab, a lot of these T cells wouldn't be there or would be immunosuppressed. So you're trying to lift that immunosuppression to allow the T cells that are there to be activated by the immunotherapy. So the combination of those two agents is what has proven effective. It's important to stress that even before those two agents, when we only had sorafenib, that sorafenib alone also has a broad range of effects, but it does block VEGF. And this is just to show an experiment that we did years ago that sorafenib does increase hypoxia in these tumors. And just like some of these other agents that we were going to discuss, provoke some level of immunosuppression. As I mentioned before, in order for the checkpoint inhibitors to work, you need to have resident T cells, or you need to attract T cells into the tumor microenvironment. Without them, no amount of immunotherapy is going to be enough. So this chart very interestingly show how approximately 50% of patients with cancer are eligible to receive immunotherapy. There is some element of their tumors that is immunogenic. However, even with the best immunotherapy, less than 20% actually display some element of response. Why is that? Melanoma is the prototypical immunogenic tumor, so it is the first tumor where these immunotherapies were described. And this important article in Cell compared two groups of patients with metastatic melanoma and their response to PD-1 inhibitors. And one of the key findings when looking at the genomics of these different groups of patients is that the difference between responders and non-responders, hypoxia and angiogenesis played a key role. So these slides are to stress the important role of hypoxia, not only on the increased expression of VEGF and increased attraction of immunosuppressive cells, but also on the other side, on its increased expression of checkpoint molecules that work to stop immunity from eliminating the cancer cells. So hypoxia plays a role on both sides. And I think it is important for us to understand, since our interventions typically affect the oxygenation of tumors as well. And this is something I think as an interventional radiologist, it is a very important study and a very important picture to absorb. These are animal models. TRAMP-C2 model is a prostate animal model. And on the other side here, we're dealing with a lung cancer model. And the green is a marker for hypoxia, and the marker that we'll see in a little more detail later. But basically shows on the tumor surface, or on this in the area of the tumor here that is analyzed, where the hypoxia is spatially located. And when you co-stain for T cells, CD4 and CD8s, you can see that where the tumor is hypoxic, you basically have an absence of T cells. Since we are treating patients with embolization, chemoembolization, we are clearly creating these green areas in our tumors. And by doing so, we are inhibiting T cell infiltration. So understanding how we do it is going to help us minimize these effects. With those questions in mind, we embarked on our experiments. We wanted to understand a little bit better the magnitude of the hypoxic stress caused by embolization and what the hypoxic stress was doing to the underlying tumor cells. You also wanted to know if different embolic agents cause significantly different types of hypoxia, and how that impacted the immune response, and if adding a drug to the embolic cocktail was of any significance in terms of hypoxia and immunity. This is we don't have to go into too much detail, but it's important to understand the concept that not all cell death is equal to the immune system. So it ranges from cell death that cannot be even seen by the immune system to a different type of cell death that triggers a positive response that leads to activation of the immune system and eradication of the other tumor cells, to a more general and broad response that combines both. So when we typically treat this with embolization or chemoembolization, we're causing a massive insult, a massive injury, and we are mostly causing this number one inflammatory cell death, where we have massive necrosis with release of a lot of inflammatory, pro-inflammatory and pro-tumoral agents that trigger both responses. Apoptosis typically is what is described as your prototypical tolerogenic cell death, where no immunity is elicited, and some tumors like melanoma cause the immunogenic cell death, with which activate the immune system, and this maturing of dendritic cells, attraction of M1 macrophages that then help eliminate the cancer. And as a sidebar, doxorubicin, which is one of the drugs that we most commonly use, also has a positive effect on immunity to cancer. Doxorubicin causes a particular type of cell death that releases this important factor, HMGB1, which basically is recognized by the dendritic cells and activate dendritic cells, which then in turn present the tumor antigens to the immune system and activate a T cell response. So it is a interesting concept to know that the presence of doxorubicin could have beneficial effects in terms of activating the immune system. Although we embolize we've been embolizing with beads and particles for a long time, there is actually a dearth of studies looking at different size particles and how they penetrate into the tumor. And of the few studies that exist, basically what they show is the vast majority of the particles, especially in the range of 100 microns and larger, will be collected in the boundaries of the tumor. Not all will go into the tumor. If anything, most of them will not go into the tumor. So Namur had this really interesting publication in 2011, where they basically explanted a tumor 8 hours after they embolized. So they embolized the tumor as bridging to transplant, and the patient then got a call and was transplanted 8 hours later. So they had the incredible opportunity to look at their tumors after embolization less than a day later. And when they dissected the tumor and looked at the tumor in the microscope, they saw that basically 50% of the beads were in the tumor and 50% were outside the tumor. And this is for 100 to 300. And on this side, it's a study done in animals, and basically shows that if you have 70 to 150 micron range, you get a little more deposition within the tumor. And if you have a larger bead, it's mostly the vessel supplying the tumor. So as you can see, the reality is even with smaller beads, you don't have the majority of the beads in the tumor. This is another very critical study to understand, because I think when we perform these procedures, we get this sense that since the inflow of the tumor is stagnant, or there's minimal flow on angiography, that there is no flow within the tumor. And nothing can be further from the truth. When you look at this study done by Johnson in 2016, they basically perfuse the tumor with different fluorescent agents before and after embolization. And what they realized is that if they did substasis, which is like typically you have a few heartbeats to clear the contrast, versus complete stasis where the contrast just doesn't move despite many heartbeats. Under both circumstances, there's still a substantial amount of residual flow within the tumors. So about 30% for substasis and 50% for stasis. So even after stasis, angiographically, you still have a vast amount of perfusion. Main differences here are that if you look at the perfusion map, just looking at the yellow on the perfusion map, there's clearly less yellow and more peripheral yellow when you embolize your stasis. And when you look at the zoom, you see newly functional vessels after embolization to substasis, and you don't see that on the stasis. But regardless of that, the reality is even under the most technically successful angiographically stagnant embolization, you still have vascular perfusion. And what does that mean to the tumor and the surviving cells? To better understand that phenomenon, we embarked on this study, which basically was done in rats, where we created a tumor in the liver by injecting 1 million of these rat HCC cells. And then we divided the rats in 4 groups, and the groups are basically bland embolization and chemoembolization. And we use small beads, 40 to 60 micron in size, or larger beads, 70 to 150. And we picked those sizes because those are the most commonly used in the clinic. I mean, most people are using something between 40 and 150 to embolize tumors with particles. And we did a more acute time point at 3 days, and then a later time point at 7 days. We measure the hypoxia with the same agent that you saw from that previous study in green in fluorescence, but this we used in conventional immunohistochemistry is pimonidazole. And it is very important to understand this stain. This is a stain that is given to the animal before you sack the rat. You can give it an hour, some people give it 24 hours. And it binds to the cytoplasm of the cells that are in a hypoxic state. The key is that the cells have to be perfused in order for the stain to bind to the cells. I mean, the stain cannot get to the cells if the cells are not being actively perfused. That's important concept, especially in the context of embolization. And obviously, if the tumor is necrotic, the cells are dead, and then we're not gonna have any true binding. These are some of the examples of the tumors that we embolized, and although they are roughly, and this is the beauty of animal models. I mean, they're very similar, and they're very consistent. There are interesting differences that we can see, even just looking at the H&E on these tumors. On the bland embolization side, you tend to see a little thicker rim of surviving cells. And we do see, nodules that seem to survive the bland embolization. And I think that is a good reflection of what we've seen in clinical practice when you do CT after some of these embolizations, and you see this mural enhancing nodules that persist. And when you look at the H&Es on the drug side, it is less. We do see less of that rim. I mean, it's just an observation. And this is something to also illustrate how we try to separate. So our pathologist looks at these different tumors and categorizes the cells in the tumors as dead, completely necrotic, something in between where the cell structure is changed but not completely disrupted, and completely normal tumor cells. And this is a close-up of one of our tumors. This is a typical tumor HCC in our rat model. This also illustrates something important about our rat model, which is that the underlying liver in this particular model is normal, which is a limitation of the model. You can see here gross pathology, how it looks like in an MRI, and how we use automated pathology, which is then revised by our pathologists to quantify the different fractions of the tumor. And why is that important? It is important because the surviving hypoxic cells are the ones that are going to drive a lot of these undesirable effects. So you can see here how the surviving hypoxic cells, the normoxic cells don't release these agents, but the hypoxic cells attract these immunosuppressors, both macrophages and the MDSCs, this myeloid derived suppressor cells, and they inhibit the effects of the T cells. They also push the phenotype of these surviving cells towards a more invasive, more aggressive cell that is more likely to lead to invasion and metastasis. So it is key once we treat that we eliminate these cells. I mean, if we leave behind a lot of surviving hypoxic cells, we're most likely causing the tumor to acquire a more aggressive phenotype. So what we found out in our experiments is that, as you would expect, the larger beads concentrate, because they concentrate in larger vessels, they cause a more widespread effect in the tumors. And when we stain for hypoxia, if you were using larger beads, you were causing greater amounts of hypoxia throughout the tumor, and that was statistically significant at 3 days. And interesting to notice that, about a week later, it all equilibrates. But, as you can probably imagine, most of the hypoxia, most of that insult, most of the injury is going to happen immediately after the embolization and not a week later. The combination of the bead with drug did very little in terms of hypoxia. So we found that by adding drug, it really didn't change how much hypoxia you're causing, but by changing the size, you are certainly causing more hypoxia. So if you use larger beads, you tend to cause more hypoxia in more places. If you're using smaller beads, maybe you're causing very severe hypoxia, but whatever it is causing the hypoxia, that area tends to die, and therefore it doesn't stain for the pionidazole. Stress cells, so these surviving hypoxic cells, what we were able to see is that the lack of drug, so when you embolize with bland beads, there was a trend that was statistically significant to leave more of the surviving hypoxic cells behind. In terms of necrosis, there was no significant difference. So if you use larger or smaller, drug or no drug, you cause more or less the same amount of tumor necrosis. So the differences were not in tumor necrosis, the differences were in the surviving fractions. The other surviving fraction is the fraction of the tumor that simply does not get affected by the embolization. And we saw that, complementary to the other slide that I just showed, we saw that that is more common with the smaller beads. So again, the smaller beads, if you are able to deliver them adequately, they will probably eradicate all the tumors supplied by the branches that they embolize, because the the embolization is so complete. But obviously, it's more difficult to cover a larger area, larger tumor with those beads. And whatever they don't go, I mean, the tumor doesn't get affected. If you use larger beads, then you're embolizing everything, but you're leaving more hypoxia and more surviving hypoxia cells behind. I mean, that is the sort of the main lesson learned from the experiments. We also wanted to look at the immune cell landscape after these embolizations and seeing how these different agents affected the cells that get attracted into the tumor microenvironment. The graph here shows in HCC in patients what the cells that are most relevant, and as you can see, it's mostly T cells, macrophages, a little bit of NK cells, and we try to replicate that. I mean, not everything is available in rat, but whatever is available. So for those not familiar with these markers, obviously the CD4, CD8, the T cell, the helpers, and the effectors we did. FOXP3 is a marker for these Tregs, which are CD4s that are immunosuppressive in action. RP1 is a marker for neutrophils. IL-17 is an important cytokine that can have tumorigenic or anti-tumor effects depending on the context of the environment. So just sort of a broad look of the different types of cells that could be present in the tumor microenvironment. So since macrophage is probably one of the largest family of cells that are seen after embolization, we studied those. CD68 is a pan macrophage marker, just means that it looks at all macrophages. There are different macrophages, and it just looks at all of them together. And as you can see here, as you would expect, after embolization, you get an influx of macrophages and this is what we're trying to show on this other slide. It's mostly concentrated in the peritumoral region. So doing embolization with drug or without drug, you're attracting macrophages. Why is that important? If you look at this diagram that I showed earlier, macrophages can go mostly two different directions, opposite directions. The M1 macrophages have a positive effect and activate immunity and T cell response and eliminate tumor cells. However, you can have this M2 spectrum where these macrophages will actually work to create an immunosuppressive microenvironment and protect tumor cells. It was before when we studied macrophages in the liver, we just treated them as an entity. But now we realize that the resident macrophages in the liver, the Kupffer cells, are completely different than the macrophages that are derived from the bone marrow and get attracted into the tumor microenvironment. They're different in mostly here. What we want to think about is plasticity. I mean, these the ones that come from the bone marrow can go that entire range of the spectrum that I was just discussing. And if you look down into this diagram, you can see all these different roles it can play, and the opposing roles. It can cause fibrogenesis or actually lysis. It can cause type 1 or type 2 inflammation. So these cells are very plastic, and how we modulate the microenvironment actually points them in one direction or another, which is what we're going to illustrate here with this next slide. So CD163 is actually a marker of those M2 macrophages. So a macrophage that has a mostly immunosuppressive effect on cancer immunity. And as you can see here, we do attract those with embolization and chemoembolization. using drug-eluting beads. So if you think about it, we are increasing, depending on the size of the bead, we are increasing hypoxia, sometimes substantially, and that hypoxia in turn, as we saw earlier in the lecture, attracts these cells, and these cells release a number of agents into the microenvironment that are mostly trying to block T-cell infiltration and T-cell activation. What about T-cells? So what we saw is that chemoembolization, had a significant increase in the presence of CD8 effector cells in the tumor microenvironment. However, what I think it's important to realize here is, not only looking at the bars, but looking at the actual numbers, and you can see that the percentage of CD8 cells in the context of immune cells, I mean, we're going from 0.1% to 0.3%. So it's still a very low number. And that's why even if the combination of immunotherapy and VEGF inhibitors is effective, it's still a very limited response because these cells are present in small numbers in HCC. Obviously, different patients, different tumors have a different number, but overall, the number is not particularly great. So even if chemoembolization and embolization increase the numbers, it still is a limited number. And a similar thing can be said about these FOXP3 positive Treg cells. These are immune suppressive cells, T cells that tend to shelter the tumor cells from immunity. But we do see an increase. We do see a slightly greater increase after chemoembolization compared to blend embolization. But again, very small numbers, probably not playing a dramatic role in the outcome. Finally, we classified the inflammation seen around the tumors, depending on the size of the bead and the presence of drug. And what we see is that inflammation, as you would expect, increases over 7 days. It does increase more dramatically when you have drug, causing more tissue injury, therefore a greater influx of inflammatory cells. And we do see it more in the larger beads. So again, larger beads, more hypoxia, greater attraction of these immune cells, often the immune cells that we don't necessarily want. This is a study that I published earlier, just to show the the IL-17 and Th17. These are T cells, a very specific group of T cells that get attracted into the environment after embolization, and it's this study that we published demonstrated that it's one of these cells that gets attracted the most after embolization, and it mostly also plays an immunosuppressive role. Towards the end, and I'll be remiss if I didn't discuss this study that was done by Duran and Shapiro, and it is very interesting. It was very early on and sort of ahead of its time, where they tried to use ifosfamide, which is a hypoxia activated drug. So this very original concept is, what if we want to capitalize on this hypoxia by giving a drug that gets activated by hypoxia and only by hypoxia, therefore with minimal systemic toxicity, and we could not only perform the embolization, but increase the amount of cytotoxicity by having this mustard agent that only gets released under hypoxic conditions. And this is a very interesting study, and that they show that the concept works. The drug is still undergoing clinical trials, But importantly to me, what I also learned from this study is that they performed a conventional test with Lipiodol. And when you look at the hypoxia, the hypoxic fraction and the hypoxic component after embolization with Lipiodol, you get a less dramatic stain, a less dramatic uh, presence of the palmitazole in the tumor cells. So that made me think that there is a chance that we could perform embolizations with the puddle and maybe cause a more moderate hypoxic insult as compared to beads, and that's something that I'm interested in, and we are currently studying if there's a difference in the type of hypoxia and the severity of hypoxia if you use Lipiodol versus drug-eluting beads. This is a summary of the experiment and a summary of the talk. It basically shows that when we use drug, you tend to get more necrosis, and if you use bland embolization, you get necrosis, but you also end up with a lot of stressed tumor cells. Just again, something to keep in mind. That's not necessarily positive or negative. I mean, as you saw with the study on ivofosfamide, sometimes we can capitalize on the surviving stress hypoxia cells in some way to increase or improve our outcomes. So the conclusion of the study is that hypoxic stress after embolization is greater than 3 days in animals treated with larger beads, and it does not matter if you have drug or not. Necrosis do not change between the different particle sizes, but we did see a little more necrosis in the animals treated with the drug. These types of treatments cause predominantly inflammatory cell death that attracts a number of inflammatory cells, macrophages, myeloid cells that are immunosuppressive, as well as T cells that are immunosuppressive. The macrophages in and around the tumor after embolization tended in our experiment to be of the M2 phenotype, which is immunosuppressive. And we did see a slight increase in CD8 cells and Tregs, but again, of limited quantity, so of somewhat doubtful clinical benefit. With that, I conclude the talk, and I hope you enjoyed, the research, and I'm be glad to answer any questions.
Well, thanks, Ronnie. That was really great. Lots of basic science, and I think that interventional radiologists / interventional oncologists really need to do more of this, because this is actually where the foundations are all built in terms of how our field progresses. So if you have some questions, we have 2 already. If you want to put them in the chat box or the question and answer, now we have 3. I'll be happy to I'll be happy to address them. At the same time, I have my own questions, but I guess I'll wait till the end for that. So the first one is that, let me see here. Can you speak to the role of, so basically we have numerous clinical trials in the pipeline, all of which combine local regional therapy and immunotherapy. Can you speak to the role of the type of embolic particle or liquid embolic used and the differences it makes in the immune response, and how this may affect the immunotherapy drug response?
Thank you. I mean, that's obviously a complex question, and I'm not going to claim to know the answer to this question. I try to show that I think as a clinical interventional radiologist, if you are using particles, this question of size is very central to the treatment. And I used to do I remember I used to do portable embolizations with David when when he was at MD Anderson, and he was very particular about the size of the particles used for PVE and the order that was used, and I think the research supports that. I think if you see in clinical practice anecdotally, or even in these preclinical studies, using smaller particles, if safe, obviously you have to be careful with tumors that have large shunts, or tumors that are close to the diaphragm and can be shunting straight into the lung circulation. But if safe, the use of smaller particles in smaller tumors is probably best if you're using particles. If you have larger tumors, then it becomes more complicated, right? Because then we see that if you don't cover everything, then basically you're leaving viable cells behind. Therefore, you probably need to go from a smaller embolic agent initially to then scaling up to a larger particle. And that is when you open the door for some of these hypoxic insults that are not lethal and that cause that activate the immune system in the wrong way. We do not know, and that's I think part of the question is we do not know how to embolize and cause an immunogenic response. I don't think that that's something we've been able to determine, how to perform these procedures and cause the cells to release the the antigens and have the antigens presented in a way to like beautifully activate the T cell response. We see more of the other side. We see more of not being very meticulous and causing a very immunosuppressive insult.
Okay, thanks. So Julius has a comment which basically states that we published some very early and less elaborate data on a similar topic in JVIR about a year ago, admittedly using the really immunogenic oncozine beads loaded with idarubicin, and found that smaller beads caused more hypoxia than the larger beads. But this was in a VX2 rabbit. Do you think that the animal model matters? I mean, obviously you used a rat model. So do you think that actually matters?
I think that matters a lot. I think that both the VX2 and the rat are basically the models that we have for our endovascular procedures, and they're both, they both have their pros and cons. I do think that, and that's something that we are studying, I do think that these models have very different vascularity, and both the rat and I mean, obviously rat, there's several different types of rat tumor models, but the models that we used, both the rat and the VX2 do not really replicate that exuberant vascularity that you see in human HCC. And I think a little bit of the limitation of the preclinical research resides there. That both the VX2 as well as the N1S1 in rat, or even the one that we use here, the buffalo, they're a little more vascular, but they're still not as vascular as a human HCC. And then that changes the amount of bead you get into the tumor, because if it has less vessels, smaller vessels, you're going to get less beads in the tumor, and these variations, like these change between this difference between Julius' study and our study, I think is certainly more likely than not due to that. The drug does play a role as well. I mean, it causes endothelial injury. Sometimes the way the drug is eluted from the bead, it may cause an earlier endothelial injury, so you don't penetrate as deep into the tumor. But I think the model is central to that.
Yeah, thanks. I mean, you, I guess, answered another question that one of our faculty had, which was on your thoughts of hypoxic stress following embolization of tumors that aren't very vascular. So I think that you've kind of already covered that. There's another one about the time course for release of doxorubicin from the from the hydrogel beads.
Yeah, so I mean, there's you know there's publication, there's literature suggesting a longer time course, days, weeks. But what we did find, and I think that that's very similar to what you would expect based on clinical observation, is that most of the effect of these, if you look at our data, 3 days to 7 days, most of the effect of these treatments occur at the outset. I don't think you see with drug-eluting beads, although this is not something that we have like done in a very controlled clinical study. But I think most people here would agree that you don't see a dramatic change in the amount of tumor that dies from drug-eluting beads months out. You know, you see the effect early on, the first few days to weeks, and then that's what you observe, as opposed to something like Y90, which can have a change in response months later. So I think, although theoretically it does elude over weeks, I don't think clinically is making that much of a difference. And in fact, when you look at the preclinical data, the the drug doesn't elute very far from the bead anyway. So I agree with Dave. We're having this discussion earlier. I mean, I agree with Dave that the effect of drugs is likely a local vascular effect. And this is what we saw in our experiments as well, that the drug just increases the amount of vascular injury caused by the embolization. You just have a more severe, robust vascular like injury by using drug on the bead. And it is a more like delicate embolization if you don't have the drug, with pros and cons of each. So the pros of the blend is you have less of that exuberant inflammatory reaction. At least that's what we saw in the preclinical models. So maybe you are potentially attracting less immunosuppressive cells. And the drug, if you add the drug, and if it's the right size bead and the right size tumor, then you probably obliterating that tumor.
Yeah, so that's interesting you bring that up because I personally don't know if the particular drug matters. And I'm not convinced that the actual drug gets into the cells the way that it would if it was intravenous. And I think that it's very important for maybe us to, at some point, look into what's actually happening at the cellular level. I did a case, I think I told you about this, where we did a case of prostate cancer mets to the liver, where we did conventional TACE with doxorubicin, and the tumors were completely dead. And I don't know, does doxorubicin work on prostate cancer? It probably wouldn't be the first choice that you would use. So I think that it has a very local endothelial injury level that doesn't correspond necessarily with what goes on at the cellular level. Anyway, we have one more question, I think, from one of our hepatologists. And basically, given some of these very interesting findings on changes in cell population, how do you think TACE will partner with some of the new immunotherapies? Opportunity for promoting modes of action given changes in hypoxia in cell populations. Is there anything known about the zones around RFA and microwave with respect to the same kind of changes in cell populations or hypoxia-induced changes? So that's really, I guess, two questions in one. So one is, I guess, about immunotherapy, and then I guess the other is about what's going on, I guess, around the cell at the cellular level in the hypoxic region, that's similar to, I guess, if you have an RFA or a microwave that you're ablating, like, like a margin.
Yeah, there's some data published on RFA preclinical, showing similar findings that if you leave, unfortunately, in ablation, if you leave surviving cells behind, the insult the thermal insult that ends up causing hypoxia, leads to a more aggressive phenotype. So in preclinical data, the cells that survive end up being more detrimental to the patient than if they're just not ablated. I'm sorry, what is the other half of the question?
And about your thoughts on immunotherapy, with all these, as you know, we have all these clinical trials. We have one here that's about to start, on, TACE with immunotherapy. What are your thoughts about that?
My thoughts are, I mean, it's somewhat, similar to what we were discussing towards the end. I think if you could have some of these embolic effects partnered with less hypoxia, you could, I think, see a more synergistic effect with the systemic therapies. And in that context, I think the embolization with oil is very interesting. I think that that if we are proving that embolization, especially with larger beads, can cause significant hypoxia throughout a large area of the tumor and surrounding liver, that could obviously hinder some of the more beneficial effects. Then maybe if we use liquid embolic such as Lopadol, we could lessen some of that immunosuppressive reaction and hopefully enhance the outcomes.
Well, I think you just got grilled by a lot of experts in the field. I think you did a tremendous job. I think that, again, this shows the work that still needs to be done. And I think, Rony, you're making like great progress in how we view chemoembolization and other types of local regional interventions that we do for liver cancer. So I think with that, I'd just like to again thank you for taking the time to speak to us today at Yale AR Grand Rounds, and we will see you soon.
Thanks for inviting me. It was a pleasure. Thank you.
Okay, thanks.